good evening, and good night, depending upon where you are. We have with us speakers who are all around the world joining us to speak today. I am told that our video will be starting just slowly, and if it hasn't been on YouTube yet, it will be shortly. So bear with us if you're watching anywhere else. We are getting a list of where everybody is watching us, and I'm going to read off where we're getting countries that have joined us already. In addition to the United States, where I am in San Diego, California, and I am David Granite, we have Canada, we have Mexico, we have Brazil, we have Argentina, we have Colombia. We're all over this part of the world, and everyone joining us, we thank you. We're all over Europe right now. England, Italy is with us, not surprisingly. We have France and Germany, Switzerland, Sweden. We have a doctor, at least one doctor from Ukraine joining us, and we pray for you that everyone there will be okay. We have people from Turkey are joining us. We have doctors from Belgium and specialists from Belgium that are here. We have Africa, Kenya, Nigeria, South Africa, the Middle East, Lebanon, Israel, Jordan, Saudi Arabia just joined. Thank you all for joining us. We have people from Singapore, from Hong Kong, from New Zealand, from Australia. We have people from Taiwan that are here. I'm going to stop because it's all over the world, and I'm just going to say everybody's here. And welcome to all of you, and thank you so much for joining us. We have a truly very, very special group of people that are here to discuss this. We're going to go in depth. We're going to give you the information that you need. We may change your viewpoint on things you thought you knew. And so I'm going to stop talking and start introducing our incredible speakers. First, David Guyton, who is the Zanville Krieger Professor of Pediatric Ophthalmology. He's the former, David, it's funny to give you an introduction because I doubt there's anybody in not only pediatric ophthalmology, but ophthalmology that doesn't know of you and the work and the contributions to our field. David Guyton doesn't know this, but since the day I found out about him and met him, I've been trying to pattern my career and learn from him. And I hope one day that I have a reputation that's as gracious and anywhere near as spectacular as David's is. He is the man, as we would say, and using it in its old-fashioned way of saying it, that he's the best of the best. And David, I'm so glad that you're here joining us. Davy Gotts is joining us, who is a member of the scientific board here at WSPOS. She is a spectacular orthoptist from Belgium, and will be talking to us today a little bit about how to measure and look at DVD. Lionel Cowell is here. Lionel is Chief of Oculomotility at the Royal Victorian Eye and Ear Hospital in Melbourne, Australia, where it is the opposite time. For me, it's 6 o'clock in the morning. For Lionel, it's after 11 o'clock at night. Max Serafino will be joining us. Max is the director of and the chief of the ophthalmology unit at the Institute Gianni Gaslini Children's Hospital. Max, I'm sure I said that wrong, and I apologize, in Genoa. Max has more energy than any 5 people I know put together, and is an absolute joy to have you with us. And then now I will send over to my co-host here, and the co-moderator with me, my dear friend, Paolo Nucci. Paolo was the head of the World Congress when it was in Milan, the president of it. He is professor, and it's Paolo in English. It looks like ordinario, which I'm shocked because there's nothing ordinary about you. So I'm assuming that means something else in Italian. Of ophthalmology in the Department of Science and Biomedicine in Milan. He is a full professor in Milan and a superstar in our field of pediatric ophthalmology and strabismus. He'll be helping host the World Society pre-day meeting at ESCRS coming up in September of 2022. Paolo, I am going to hand over the rest of the introductions and the rest of beginning our talk to you.
Thanks, David. This is really a pleasure. It's my great pleasure to introduce you, the one who made all this pediatric ophthalmology cyber world possible, and also very, very effective. All of you know David Granite, co-executive director of the WSPOS, professor of ophthalmology and pediatrics. I want to tell everything about you. All of us know you perfectly. With us to animate the discussion, we have the pleasure to host Birsen Koki-Yiğit, professor of ophthalmology at the Istanbul Yeni Yüzyıl University, and also my good friend, Richard Hertel, chair of ophthalmology, professor, Department of Surgery, College of Medicine, Northeast Ohio Medical College, and so on. And also Anna Horwood. I learned a lot from your papers, Anna. Anna is an emeritus professor of orthoptic and visual development, University of Reading, UK. So at this point, David, I think that we have to remind that the audience of the question could be forward typing your QS on the YouTube comment section. And can you just go on with another slide? So we want to remind you that if you send an email to this email address, admin wspos@wspos.org, you can get the participation certificates. At this point, let me introduce one of the pediatric ophthalmologists who dedicated his professional life to education, exploring the most complex part of strabismus, and among them certainly to the obscure world of DVD. And Professor David Guyton, please, can you share your screen with us and start with your presentation?
Yes, thank you, Paolo. In the interest of accuracy and timing, I've actually recorded this session, and so we're going to start right now. And like there we go. I have no relevant financial interests. This story begins with latent and manifest latent nystagmus, now known as fusion maldevelopment nystagmus, or FMN. Please excuse me if I still call this latent nystagmus. This arises from deficient binocular development in early infancy, such that with unilateral fixation, the fixing eye drifts in, usually down, and in torts, with corrective saccades producing characteristic nystagmus with decelerating slow phases. But latent nystagmus is only one type of nystagmus in infancy. The other primary type is infantile or congenital nystagmus. Both types decrease vision. It's known that infantile nystagmus can be damped by convergence, improving vision, but can convergence damp latent nystagmus? Joseph Lang wrote, no, latent nystagmus is blocked by binocularity, not by convergence. Gunter von Norden wrote, manifest latent nystagmus, a condition in which active dampening of the nystagmus by superimposed innervation plays no role. Annette Spillman wrote, manifest latent nystagmus is not blocked by convergence. But they were all wrong, through no fault of their own. They just did not have sophisticated enough recording equipment to see this damping phenomenon. The best they had was electronystagmography, recording DC potentials on the skin, in this illustration from von Norden's last text in 2002. These were almost always just horizontal recordings. This instrumentation just cannot compare with scleral search coil recordings, which can measure the horizontal, vertical, and torsional positions of both eyes simultaneously 500 times each second, here showing striking latent nystagmus in all three dimensions when the right eye is suddenly occluded. Now, using recordings like these, I aim to show you how and why dissociated deviations develop. Here is a scleral search coil on an eye anesthetized with proparacaine. 24 years ago, my colleagues and I, with the expert help of Dr. David Z. at the Wilmer Eye Institute, obtained complete bilateral scleral search coil recordings of 10 young adults with DVD under various fixation conditions, even with head tilts in some cases. We're going to look at some of the tracings. These tracings are of a 20-year-old patient with DVD. Initially, the left eye is fixing, cool colors on the baseline, and the right eye is slightly misaligned, the red and orange tracings below the baseline. Then the left eye down at the bottom is suddenly occluded. Several things rapidly happen. Strong latent nystagmus appears, then a refixation saccade brings the right eye up to fixate. Instantaneously with the beginning of the saccade, the left eye shoots up, the cyan tracing, and adducts strongly, the green tracing, with the resulting vertical vergence creating a left hypertropia and a convergence creating a left esotropia. When a saccade occurs with a vergence, the vergence blends with the saccade, and they both happened very fast. Note that the initial strong latent nystagmus damps out in about half a second as the vertical vergence and convergence occur. It happens so fast that you will just see the left eye turn up and in, and you will deny that there was any latent nystagmus present. But let's take a closer look at this initial strong latent nystagmus. The intensity of the latent nystagmus is measured by the slope of the slow phase. The right eye is shooting in, down, and intorting, with these movements being almost totally damped by the dissociated movements then occurring. When cover testing a patient with DVD, the latent nystagmus is often damped so quickly that it cannot be appreciated clinically. But in some cases, the damping is slower, with latent nystagmus appearing initially and then becoming damped as DVD develops. Here's an example we can see. The latent nystagmus in this 6-year-old girl increases when reading small letters and then is damped by further DVD developing. First, the baseline DVD.
Good, that's a good one.
Then reading small letters.
Letters.
The nystagmus showing up and then being damped as the eye moves still higher.
Good, that's a good one. Read the letters. Take away.
What did we learn from studying our scleral search cold recordings? In all 10 of the DVD patients we recorded, latent nystagmus appeared or worsened when one eye was covered, and the latent nystagmus became damped, especially in the fixing eye, as the DVD developed. What were the primary muscles creating the vertical vergence in the DVD response? These could be identified by analyzing the simultaneous vertical and torsional movements of each eye as the vertical misalignment developed. The fixing eye moved down and intorted, implicating the superior oblique muscle. The non-fixing eye moved up and extorted, implicating the inferior oblique muscle. Let's illustrate the DVD movements. With occlusion of the left eye, latent nystagmus occurs and DVD develops. The right eye moves down and intorts, implicating the superior oblique muscle. The left eye moves up and extorts, implicating the inferior oblique muscle. A left hypertropia develops, accompanied by a cycloversion. But to maintain right eye fixation, an upward version occurs, with the end result being a left hypertropia and a levocycloversion. What can we say about this oblique muscle-mediated vertical vergence / cycloversion? It's actually an ocular motor mechanism normally used by humans for small amounts of vertical fusion. The vergence component damps the cyclovertical latent nystagmus, improving vision, and therefore many infants and toddlers with latent nystagmus randomly discover this mechanism and learn to hijack and magnify it because it helps them see better, with the unfortunate side effect of creating DVD. This is the primary nystagmus blocking vergence occurring in DVD, well documented. Let's list the various eye movements in DVD. Latent nystagmus with comitant drift and corrective saccades. Then we have the exaggerated vertical vergence created by the oblique muscles, which also create a cycloversion and a passive divergence because the oblique muscles have tertiary abducting action. Then there are vertical versions to maintain fixation by the fixing eye, and finally fixation saccades to switch fixation from one eye to the other. As an interesting aside, each vergence and version eye movement obeys Hering's law after all. It's just the combination that gives the illusion that Hering's law is not obeyed. What more can we say about the DVD response? It's a learned response to improve vision in the fixing eye. This is similar to the infant with unilateral superior oblique paresis learning to tilt the head for better vision. The vision is better, so the infant keeps doing it. The learned DVD response is often asymmetric between the two eyes, because there's no reason why each eye should learn equally well. The DVD response often becomes an anticipatory response. This is similar to the person with constant strabismus shifting fixation from one eye to the other, anticipating and automatically making the necessary aversion to maintain steady fixation on the same object. This anticipation often combines the DVD response with a fixation switch, which greatly speeds the DVD's vergence, hiding any visible evidence of latent nystagmus or its damping. Let's go back and look at the dissociated horizontal response in these various sets of tracings. Here the right eye, the red tracing, takes up fixation straight ahead, and the left eye, the green tracing, turns way inward, more than 15 degrees, representing a huge convergence. Whenever the green tracing is higher than the red tracing, we have an ESO deviation. We have seen how well vertical vergence damps the vertical component of the latent nystagmus. It should not be surprising that this large convergence very effectively damps the horizontal component of the nystagmus. The initial large horizontal nystagmus in red damps out beautifully in less than half a second. Here is another example, this time with a right DVD developing when the right eye is occluded. There is an esotropia initially, which remains about the same throughout. There's no convergence occurring in this dissociated response. And note that there is essentially no damping of the red or the green tracings, representing the horizontal component of the latent nystagmus. But the vertical component of the latent nystagmus, the cyan tracing, is nicely damped by the vertical vergence supplied by the DVD. So we see that the horizontal damping mechanism can be quite separate from the vertical damping system. In DHD, we have latent nystagmus, the horizontal component, with the comitant drift and with the fixing eye drifting inward and the corrective saccades. Then we have the active convergence created by the medial rectus muscles. We now have seen that this active convergence damps the horizontal component of the latent nystagmus. Then the horizontal versions to maintain fixation by the fixing eye, and finally fixation saccades to switch fixation from one eye to the other. So enabled with increasingly accurate methods of eye movement recordings, various investigators, beginning in about 1990, began to document that the horizontal component of latent nystagmus is indeed damped by convergence. It had previously been shown that convergence damping of infantile nystagmus improves vision, and more recently shown that convergence damping of latent nystagmus improves vision. In 1990, dissociated horizontal deviation, or DHD, was popularized by Wilson and McClatchy as a slow, spontaneous divergence of the non-fixing eye with inattention. They used a Buchovsky phenomenon type test to confirm the dissociated deviation, but this test was not as pathognomonic as they thought. We now know that such patients have an underlying exotropia, and that the dissociated deviation involved is actually an active convergence tending to straighten the exodeviated eye. The previously described slow divergence was simply relaxation of the active convergence occurring upon inattention. DHD as a dissociated convergence has been studied and documented by a number of investigators since 1990. Regrettably, book chapters continue to be published describing DHD as a dissociated exo movement. How does DHD behave? DHD, when present, is always a convergence phenomenon. Because it damps latent nystagmus and thereby improves vision, it becomes a learned, often anticipatory response. As with DVD, DHD can merge with refixation saccades and happen so very fast that the latent nystagmus cannot be detected visually. But why is DHD not more obvious, if it's so common? With DVD, the hyperdeviation with each eye fixing is in the opposite direction, easy to see. But with DHD, the horizontal deviation, the convergence with each eye fixing, is in the same direction. And if the DHD is equal with either eye fixing, the DHD is practically impossible to detect. It's only the asymmetry that we can detect with prism and cover testing. If there's equal DHD, methods to detect dissociated deviations that do not work are the Buchovsky phenomenon and the reversed fixation test. Methods that may work with equal DHD are Spillman's method of bilateral occlusion with translucent occluders, looking for a divergence shift behind the occluders, which I intend to start looking for. Or a new test that I stumbled upon only recently, occlusion of the non-fixing eye, looking for an ESO shift behind the occluder. I made a video of this. This test depends upon physical occlusion of the non-fixing eye stimulating an increased dissociated deviation, which is usually the case. This 10-year-old patient has a plano refraction and a left exotropia, about 10 prism diopters. With his reading letters with his fixing right eye, we will occlude his left eye. Watch the ESO shift of the left eye when occluded. Try not to blink when it comes in. Only a DHD will do that. It remains to be seen how useful this test will be. What is the significance of all of this? If these mechanisms underlying the development of dissociated deviations are correct, the prevention of latent nystagmus should probably be the target of future investigations. We can prevent the development of latent nystagmus. We can prevent DVD, prevent DHD, and prevent the secondary changes that occur, actually prevent infantile esotropia itself. A lot to think about. Thanks very much.
Wow, David, a lot to think about indeed. Bravo. And thank you for summarizing the work that you've been doing, not just this week, not just this year, but for well over 20 or 30 years, it looks like, or probably your whole career, you've been thinking about it. So thank you for sharing about it. I'm going to take a few seconds and make sure that I understand it because I've heard you give this talk and I want to make sure that I get it, that the manifest DVD that we see a child walking around with is in part that anticipatory or already created DVD that's being used to damp the latent nystagmus. And that the initial movement is superior oblique mediated in the fixing eye that drives both intorsion and depression. And this happens all so quickly. The non-fixing eye has the extorsion from the inferior oblique. Now we have a vertical misalignment of the fixing eye, which has to refixate by elevating. And in doing so, via Hering's law, drives the non-fixing eye up and we see a DVD.
That's correct, but it all happens almost simultaneously, not in individual steps. But you got the steps correct, but it's all blended together by the anticipatory right.
And the refixation movement of the fixing eye is not large, but the DVD sometimes is much larger. In other words, it's asymmetric in terms of the movement that we see. That would seem to violate Hering's law in terms of equal innervation to both eyes. How does that come together?
Well, the refixation movement you're talking about, you never see because it's happening simultaneously with the DVD response. It would be very, very large if it were done subsequently, but you never see it because it's happening at the same time. So I wouldn't say that the refixation movement is small. It's just hidden by the big divergence that's happening that's creating the DVD.
I see. So it's happening quickly enough that we're not seeing how big it is because the DVD is often overtly large.
Right. It's an anticipatory response. The patients learn to do them at the same time because that's how they should end up.
Fabulous. Okay. We have Rich Hurdle with us. Rich, your work was with Lou DeLoso was alluded to as part of David's talk. And you've spent your career studying nystagmus. And I'm wondering if you have any thoughts or comments to help kick this off.
Thanks, David. And David, thanks again for allowing me to listen to that. And every time I listen to it, I think of something else. And I have three things quickly to make. I don't want to take up a lot of time. The first is I share your frustration with the discovery of new ideas and then textbooks coming out with the old ideas. You know, and in 1974, Dave Kogan said, don't call it congenital nystagmus anymore. He said that, and he said it 6 years after he named it. And so for 40 years, people have still been calling it congenital nystagmus. And I've been trying to change it for 30, even with an international symposium. And I'm glad that you said at least you recognize there's a new term, but you don't like it and you want to use your old term, which is fine. That's my first point. The second point is that if I do eye movement recordings on every single child with infantile strabismus syndrome or the old congenital esotropia, they all have oscillation. They all have latent nystagmus, whether it's visible or not. That it seems to be part of interrupting the binocular system at that sensitive period in development. And the third point is that you're positing this the DVD on a vergence response, which you see with the eye movement recordings. There's no doubt. But where is the vergence response coming from in patients who have infantile strabismus with no fusional vergence? So you're eliciting a pure motor vergence response. So analogous to if I had no binocular function and I asked someone to converge at near, the vergence response is not driven by, very little by nasal and bitemporal disparity. It's mostly there's an additional effort to see. So what you're pointing out is if this occurs universally, is that you don't need an afferent fusional vergence ability to generate DVD using a vergence response, which could be almost pure motor. You're saying we have a pure motor vergence response, which is not talked about a lot in the neurophysiology of strabismus.
I think that's right. It's because the mechanism of the superior oblique driving the one eye down and the inferior oblique driving the other eye up seems to be a natural mechanism that's available to use. And that's what these people harness because they happen to hit upon it and realize that, gosh, it makes vision better, so they keep doing it. But I think it is a pure motor response because there's no chance to learn a fusional vergence response because the eyes have been decorrelated since early life.
So you're right. So there's a reflexive motor response that's generated because of the nystagmus, not because of diplopia, right? And not because of some sense of misalignment of the eyes. This is general. So the brain is responding to the oscillation and reflexively adapting to it by initiating a pure motor vergence response. That is just phenomenal because we can do that. And then the babies do that with their heads, right? With nystagmus, they do that with vergence. There are situations where when you move the eye, especially with FMNS, as you move the eye into adduction, you could do that either with aversion or a vergence response. Everyone's nystagmus will damp. So alternating with fixation with an adduction null in a large angle infantile esotrope with FMNS is they're probably nulling their nystagmus for two things, not just the DHD DVD, but they're also putting their eye in the direction of the slow phase, which does increase their foveation. So putting their head away from the fixing eye, away from the direction of adduction is part of the other compensatory mechanism in these patients. And I'm not sure why some kids use it and some kids don't. Some kids learn how to use it better than other kids. So that may be why there's so much variability in what we see clinically. Good
points, Rich.
I could hear all this stuff, David, for endlessly. But unfortunately, we have to move on, David.
So, Paolo, yes, we do. But Anna has been patiently waiting, and I want to make sure she gets just a moment to speak. And what I wanted to add is that throughout this webinar, we will be referring back to some of these issues that have come up because they will drive some of the decision making and thoughts about measurements and surgery. And what Rich has just mentioned, the automaticity of the child finding this on their own to improve their vision, like a head physician might, is fascinating. Anna, we want to make sure we have a chance to hear your thoughts.
Just very quick thing that very early infants, before about 2 months, have this convergence bias. So it shows out in neonatal misalignment and asymmetrical OKN. Do you think is this a primitive type of convergence that then gets hijacked by disparity-driven vergence for typical children, that these children with, no fusion maldevelopment problems just stay with the primitive system? And the other thing is, why does convergence or adduction dampen nystagmus? And we all know that it does, but can somebody explain to me why?
I've looked for that myself, Anna, and it may be a competition at the motor end plate of this increased innervation coming in and overwhelming the latent nystagmus innervation that's causing it, but nobody knows for sure, and that's curious. I in the lecture that I gave at the APLOS meeting a few weeks ago, I used this whole process we just talked about to suggest that DHD happening very early and very robustly in these patients is actually causing infantile esotropia, like Edelstein and Cooper's posited back in 1966. So I think we're getting into something here that can be very important in the future if we understand it even better.
But we do know that that convergence damps the nystagmus, because when we do the recordings on these patients, as I mentioned before, if you look at the slow phase, which is where vision is degraded, the foveation increases at the end of the slow phase in FMNS. So these patients are using convergence damping with FMNS, and also with INS. They both do it. They change the characteristic of the slow phase of the nystagmus, giving more vision per beat. And so the motor adaptation, the vergence adaptation, whether it's disparity driven or just a fusion response, is there to make each beat of nystagmus better and improve visual function.
Pearson?
I like to ask, in the light of the presentation, can penalization instead of the patching or other methods that do not impair the binocularities, may it prevent DVD in the treatment of amblyopia?
We do know that Annette Spillman has talked about bilateral occlusion with translucent occluders, and often the DVD goes away and the DHD goes away as well. But that doesn't happen always. In fact, patients who have a preferred fixation with one eye can do it in the dark, just voluntarily. You can ask them to imagine fixing with the right eye, and the left eye goes up in the dark. So I don't know, with patching, we have much of a chance to treat DVD.
Okay, thanks.
So, David, what do you think if we proceed with Daisy Goetz? Daisy, please, this is your time.
Well, Daisy puts her slides up. Rich, in terms of language, and for David, we've been, some of us have said damp nystagmus, some of us said dampened nystagmus, which Gene Helveston pointed out meant wetting nystagmus. But if I look at the literature, we see half the articles say dampen and half say damp. Forgive us if we use that wrong, but at some point you can let us know what way is preferred today. Daisy, all yours.
Yes, thank you very much for the invitation to participate in this webinar. And my talk of today will be clinical assessment and non-surgical treatment of dissociative vertical deviation, or DVD. As you all know, in DVD, the eye drifts upwards spontaneously or after being covered. The condition usually affects both eyes, but can occur unilaterally or asymmetrically. It's often associated with latent or manifest latent nystagmus, and as well as occurring with infantile evosotropia, it can also be found associated with exotropias or vertical deviations. Again, the eye under the cover. Discuss. The eye on the cover progressively elevates with continued dissociation, but returns to its original position on removal of the cover. the vertical deviation is nearly always bilateral, but often asymmetrical, often larger in the squinting eye and larger at distance fixation. Any hypotropia present with both eyes open will change to hypertropia under cover. And the degree of elevation of the covered eye remains the same in adduction and abduction if no vertical muscle dysfunction coexists. In most patients, the covered eye extorts as it elevates and intorts as it resumes its original position. An incident of latent nystagmus up to 100% is reported. Either an A or V pattern may be present, a head tilt may be present, and binocular vision mostly is absent. We have suppression of the deviated eye. A DVD typically becomes apparent between 18 months and 3 years of age. It's rarely seen under the age of 1. The onset is later than the associated strabismus or nystagmus, and it may also occur after horizontal muscle surgery. If we then want to investigate DVD, we have to evaluate the hypertropia in primary position, fixating with the right and the left eye. In a symmetrical DVD, the hypertropia will be about the same in each eye. Mostly we will have no vertical deviation in primary position and an equal overaction of the vertical muscles. In asymmetrical DVD, the hypertropia will be larger in one eye than in the other covered eye. And then you may have a manifest vertical deviation in primary position or an unequal overaction of the vertical muscles which coexist. The Buchovsky darkening wedge test is designed to diagnose DVD and to differentiate with inferior oblique overaction. How does it work? Patients fixate a light, one eye is covered, and you see the elevation of the covered eye. Then a red filter is introduced in front of the fixing eye, and the density of the red filter is increased. As the light entering, the fixing eye is reduced. The eye under the cover will slowly move down and can even move down below the midline. If then the density is decreased again, so it becomes clearer, or the red filter is removed, the eye behind the occluder will return again in his elevated position. And this is what they call the Buchovsky phenomenon. Another very quick and easy test to diagnose DVD is the Spillman occluder test. And here with one eye covered, you see the elevation of the covered eye. And when you occlude both eyes with a semi-opaque occluder, you get a fixation-free position, and then no vertical deviation is seen. It's also important to evaluate the hypertropia in lateral gaze, fixating with the right and the left eye. If there is no vertical muscle dysfunction, the hypertropia of the right and the left eye will be about the same in adduction and in abduction. If you have an inferior oblique muscle overaction, the eye in adduction, here the hypertropia will be larger than the eye in abduction, so fixating with the adducted eye. And you will mostly also find a V pattern. In case of coexisting superior rectus overaction, you will have that the hypertropia is much larger in abduction than in adduction. And you will also find an A pattern. If we then want to measure the DVD, then we can do this in an objective or in a subjective way. In an objective way, we do the alternate prism cover test, and then we first measure the hypertropia of here the left eye, fixating with the right eye, and your prism bar base down will be increased until there is the neutralization of the movement of the hypertropia of the left eye. Then the patient fixates with the left eye, and you measure with your prism bar base down the hypertropia of the right eye. And in this way, you have a correct measurement of your hypertropia with right and left fixation. And this can be done at distance and near. If you have to measure your hypertropia in a subjective way, for example, if the nystagmus is too difficult to see very good in an objective way, your hypertropia, then you hold the Maddox in front of one eye and your prism bar base down in front of the Maddox glass. So first the patient will see the red line below the light, and then you increase your prism bar until the patient sees the line through the light. And then you have your the subjective measurement of your hypertropia of your left eye, and you do all the everything again in front of the right eye. And this again can be done for distance and near. Of course, if there is a deep suppression, this test is not possible. And my favorite is to measure the DVE in the synoptophore. It's a very easy and quick way. It gives a very good dissociation, and you can measure your horizontal and vertical deviation in a very correct and easy way, fixating with the right eye, measuring the hypertropia and or horizontal deviation of the left eye, and fixating with the left eye and measuring your hypertropia of the right eye. And then, or a non-surgical treatment of DVD, well, actually, there is not so much we can do for patients with DVD. In case we have an asymmetric DVD or a unilateral DVD, we can try to manipulate the refractive error to change the fixation to the more affected eye. So here with optical blur, we can try to get that in this case that the left eye is a fixing eye, because if the elevation of the right eye, you don't see so much. So this is a way you can mask a little bit an asymmetrical or unilateral DVD. Prisms or exercises, I don't do that for treatment of DVD. Mostly patients with DVD where the hypertropia is bothering too much, they go over for surgery. Thank you very much for your attention. And I like to invite you for the IOA conference, which will be in 9 to 11 of June. And of course, for the Wspos Subspecialty Day. Thank you.
Thanks so much, Izzy. That was fabulous. So David Guyton, we just heard sort of the classic ways that we think about DVD. In fact, the name dissociated vertical deviation is used. And yet what you described, which happens so fast and so quickly that we don't normally see clinically, implies some differences from what we just heard Daisy describe as all of our classical teaching. Can you put those two together for us, for the clinician?
Well, yes, you really do. All these things combine to look like a dissociated or non-Hering's law phenomenon. But if you break everything down into the version and vergence components, each of them does obey Hering's law. And you'll never see that clinically because they all happen so fast and all together.
And so that if we do classic treatment when we see a DVD, many clinicians will patch the better seeing eye to improve the use or a vision out of the eye that manifests the DVD if there's a less preferred eye. What does that imply for dampening the nystagmus and the overall vision of the child?
Well, you're patching for amblyopia treatment, basically. So that's the standard. And the fact that you have DVD, perhaps more with one eye than the other, often change over time as age progresses, as experience progresses, as the patching of amblyopia progresses. So it's the two eyes are different. They're asymmetrical. They learn differently how much to do to create DVD, and so it's a mixed bag.
So if DVD is a response to trying to dampen nystagmus in the fixing eye, and we treat amblyopia, which doesn't necessarily mean that we improve binocularity, why does it change the magnitude of the DVD?
The magnitude of the DVD is an individualized thing, and people learn to use it or not use it. And I suspect that if you improve the vision in the fixing eye and make that eye work more of the time, the brain may indeed learn how better to use DVD. But I don't know why the amplitude should change once it's already present. So you ask a good question.
Great. Panel, anybody else want to comment?
Yeah. David. So one of the things that's really interesting about chronic DVD, both clinically and using the recordings, if you do the Buchovsky head tilt test, then you can either have an ipsilateral hyper or a contralateral hyper, depending upon how long the patient has had the DVD, whether it's been treated medically or surgically or optically. With chronic DVD, the head tilt, the left hyper is positive towards the side of the DVD. With early onset or DVD that still has some binocular function, the head tilt is positive towards the ipsilateral side. So you get an opposite hyper. And what I've written about, hypothesized, is that chronic DVD, and this was stimulated by Dr. Jampolsky with my training, is that long-standing DVD, you get actually a secondary contracture of the superior rectus because the eye's been up. And so that shifts it from a contralateral hyper to an ipsilateral hyper, because now the superior rectus is being stimulated by the utricular system on the left. So that depending upon when you study DVD and how you study DVD, there's an early onset, there's obviously a large supranuclear component to the deviation. But as the deviation goes on in the life of the child, especially untreated, especially if there's amblyopia and there's a strong preference for one eye, then you'll actually get a secondary infranuclear component. So now the DVD is not just a supranuclear eye movement problem. It's a complex combination of both neuromuscular and muscular and supranuclear versional vergence changes.
Max?
Yeah, thank you. I want to ask if there is any role for the prism undercover test to measure DVD, and if there is any role for the simultaneous prism cover test. I mean, we know there's DVDs as a latent component and a manifest component. So I was wondering if also the simultaneous prism cover test could be useful, and also the prism undercover test. Thank you.
Well, I think we want to have the complete deviation. So that's why you first do your cover uncover, and then finally you do your alternate cover test to get the complete amount of your vertical deviation. Because if you want to do surgery, I suppose that you want to know how much is the maximum elevation of the eye you will get.
David, is it true that I see in the list of the audience, there is David Z participating to this meeting?
Yeah, I have a feeling that's David Guyton here. David Z wanted to hear what was being discussed.
I did send David Z the announcement of the meeting, so I think he's probably on.
Terrific.
That's great.
David Z. And we have a bunch of audience questions that are coming in. We have more people that are joining us from India, from China, from Poland, from more from Ukraine. Again, we wish them only the best. Norway, Finland is here. I'm done with that. Okay, Anna,
please.
Yeah.
I was asked a question for Daisy, but for everybody, all the gurus here. There must be some environmental advantage on not letting it become manifest a lot of the time. I was going to ask Daisy how she assesses binocularity, but is there a general consensus that we need a better way of assessing very peripheral fusion, which is probably what these kids seem to have? And well, Daisy particularly
even try to measure your fusion when correcting your deviation. So with the prism bars with the children, it's quite difficult to measure it. So I would suggest that if you do a synoptophore measurement and you measure your DVD in synoptophore, that you continue and trying to do your see if binocular vision is present, and then you can use your large slides for peripheral fusion, the small one for the central fusion. What I also do is the 15 or 20 prism test, because that's an objective way to see if binocular vision is present. And then, well, stereo is not so often seen. So yeah, you can always present a line test, for example, to see if children have any stereo acuity.
They must be doing something. They must be controlling to something. And I get the feeling that we're not getting a handle on what they're controlling to. You know, I think perhaps the Bagalini striated lenses, but I still think we're missing something out in the periphery that's sort of locking them broadly straight-ish, that we don't have a good test for.
I hate to be picky about this, Daisy, sorry, but we have to move on to Lionel talk, otherwise we are a little bit late. Okay, Lionel, please.
Thank you. Well, I've started with my last slide, so let me start with my first slide. Well, firstly, David, we're here because of you. You have explained to us all what's happening with DBD, and DBD is to improve acuity with a fixing eye. We need to block its torsional nystagmus. Then the infraoblique and superior rectus of the non-fixing eye are recruited, and that's the DVD. And then, as Richard pointed out, and Smith-Kettlewell have emphasized, this eventually causes tightness of the superior rectus, and if bad enough, will cause a progressive uncosmetic hypertropia, and the ones we get to see to treat are typically quite large, and as Rich pointed out, will have the positive force tilt test. Issues in fixing these patients. When do we do surgery? Unilateral, bilateral, symmetric, asymmetric, which muscles? We are unfortunately mostly in a data-free zone, and we rely more on eminence-based medicine than evidence-based medicine. Threshold for surgery, abnormal appearance. By the time the DVD becomes symptomatic, the superior rectus is tight, the infraoblique may also be tight, and is typically more than 15 prism diopters. The expectations of surgery, we tend to accept normal appearance as a good outcome. When would you consider unilateral superior rectus surgery? Well, you can consider it when you will never get a fixation switch, say if you have dense amblyopia. But what about the child with mild amblyopia? If a child is 20/30 vision and we do a large superior rectus recession of the non-fixing eye, there will now be a mechanical barrier to keeping that eye on the horizon, so-called fixation duress. So we have a mechanical barrier to the surgically operated eye and a sensory barrier, say 20/30 amblyopia, to the non-fixing eye, and some patients will now switch to the non-fixing eye, and this will create a whole new set of problems. DVD of the right eye and fixation switch diplopia. So unilateral superior rectus recession with mild amblyopia, I recommend you plan bilateral surgery as the first step, or at least prepare the patient for an early second surgery, and read the recent paper by Max and Paolo which was published earlier this year. The first surgery. The force duction test will determine if the superior rectus is tight, and that's the usual case. And if it's not tight, you can consider infraoblique surgery. If you've had previous planned or likely two muscle horizontal surgery, I would not do superior rectus recession. If you have the complete hand for infraoblique overaction, then you should do infraoblique surgery. Superior rectus surgery, as we'll see in a moment, small, medium, and large. Consider adding a Farden. Do you do symmetric or asymmetric surgery? And there's an interesting paper on why split superior rectus that I know nothing about. Infraoblique, anti-transposition, and you either just pin the anterior corner to the lateral edge of the inferior rectus, or you spread the insertion and suture both corners. Or you can do a resect, and we'll see in a moment some people do infraoblique myectomy. Cochrane studies are always useful, and Jonathan Holmes' group, when he was at Mayo, did a very nice Cochrane study comparing superior rectus recess with superior rectus and Farden, anti-transposition with anti-transposition and resect, anti-transposition with infraoblique myectomy. Their conclusions: the surgery that was done was usually superior rectus, personal preference of the surgeon. There's no compelling evidence regarding which type of surgery is the more effective, and there's no difference in the complication rates. So there's no good evidence for anything. Two internationally important authorities, the Brazilians and Argentinians, and Bert Kushner. These are their tables for superior rectus recession doses. And as you can see, they're quite different. Not quite sure why they're so different. And Bert's recommendation are, if there is asymmetry in the DVD, you do 2 millimeters less on the eye with the smaller DVD. A very interesting paper from Delhi, New Delhi, and Dr. Molinari was also a co-author here, and they looked at symmetric and asymmetric superior rectus recession, and their conclusion was not very comforting. Only 2 out of 3 patients had a good outcome, and the probability of successful outcome did not depend on the age of surgery, the preoperative deviation, the magnitude of the DVD, the symmetry of the recession, or the surgical technique. So their experience, their retrospective experience, doesn't guide us into how to handle asymmetric DVD. Problems with the superior rectus recession: upper lid retraction, hypertropia, and month 2 slippage. I've seen this, unfortunately, a few times. And this was first alluded to in Dr. Romano's old journal, now out of print. When you do the hang-back superior rectus surgery while the eye is pointed down, is pulled down, you don't appreciate that when the eye elevates, that the superior oblique is going to get in the way of your potential superior rectus scar to the sclera. And Dr. Kushner has also shown us in some nice diagrams how if you do not separate the superior rectus superior oblique frenulum, that the superior oblique moves with the superior rectus and may interfere with the superior rectus sclera scar. And this can cause the eye to nosedive, as Mark Greenwell pointed out, a few weeks after a good result. and both he and Irene Ludwig and now myself will tend to use mersaline for the superior rectus operation. So, what do I recommend? Superior rectus recession, usually bilateral. Use Burt-Kushner's tables, modify slightly for asymmetry. If you're doing a hangback, use mersaline. If you want to do a fixed recession, you can use Vicryl. Do anti-transposition of the inferior oblique if the superior rectus is not tight, if there has been previous or likely to need 2 muscle horizontal rectus surgery, if the patient has a full hand for inferior oblique overaction, and if there is asymmetry, add a small resection for a bigger effect. The second surgery, after previous superior rectus surgery, anti-transposition of the inferior oblique, inferior rectus, plicate or resect. I've done very few of those. Superior rectus re-recession, especially if you know that you or the previous surgeon has not done a large recession, say only 5. After previous inferior oblique surgery, if you've done a previous recession, you can convert it to anti-transposition. Otherwise, I would do a superior rectus recession, and I would use smaller numbers than in Kushner's tables. DVD associated with A pattern. Complicated problem. A small A pattern will be fixed with superior rectus recession, and I'll refer you to the father and son Velez team from Medellin and California and Duke. This is a seminal paper on how to handle this uncommon problem if you have a large A pattern. Thank you very much.
Thank you, Lionel. That was fabulous as always, and very much appreciated. Whenever I operate on anyone, I always try and make sure I have a goal. What's the goal that you're trying to achieve in the surgery that you described? David Guyton has talked to us about DVD is to damp latent nystagmus and as such improve vision. What is the goal of the surgery?
The patient is presenting with the end result of something that begins with the mechanism that David Guyton has demonstrated so beautifully. But the end result is a large uncosmetic hypertropia caused usually by a tight superior rectus from having a frequent hypertropia for years. And that's what we are now treating. We don't treat the problem that David describes as causing the DVD. We treat the long-term effects of having an increasing change in the length tension curve of the superior rectus, and eventually a shortening of the superior rectus that you can demonstrate.
I'm going to get there quicker. You're trying to make the patient look better?
Yes.
No, I mean, let's just say it, right? Because
yes.
We know that in fusion maldevelopment nystagmus, binocularity can help dampen nystagmus. David Guyton has talked to us about how this whole process that leads to DVD damps nystagmus. That's all for vision. We're not trying to achieve either of those with the surgery. David Guyton, I'm trying to lead to this question, which is, are we missing something? Are we missing something in how we approach the surgery of DVD that you're trying to get us to listen and hear that would do something more effective for the patient?
Sometimes doing appearance improving surgery, sometimes that will result in easily demonstrated apparently newly acquired sensory fusion, and that's terrific. And that's a bonus. Usually why the child or adult comes to see me with DVD is because they're unhappy with their appearance.
But David, can I tell you, jump into this, I've never operated on a DVD with the expectation of an improvement from a sensory point of view. My choice to operate these children or these boys, these girls, is just for a cosmetical reason. So we don't have to hide behind the hand. This is the reason. We do operate for cosmetical reason. For me, 100%.
And I think that's hugely valuable. I just was wondering if David Guyton could guide us. Is there something else we can gain out of this?
Well, I have a question for Lionel. First, let me ask him. Lionel, I've never been very much impressed with tightness of the superior rectus muscles, and you base a lot of your procedure on that. How would you grade from say 1+ to 4+ the tightness that you feel?
Firstly, this has been demonstrated in a laboratory situation at Smith Kettlewell in one of their symposia decades ago. In the operating room, I'm lucky enough to be able to do nearly all my surgeries with general anesthesia, so I can assess the tightness of superior rectus in both eyes simultaneously. I will grab with the locking forceps, I'll grab the limbus at 12 o'clock, make sure I don't push the eye into the orbit. So if anything, I will actually lift the eyes out of the orbits ever so slightly, and then depress and abduct. And it's either clearly normal, clearly abnormal, or clearly very abnormal asymmetry in the tightness of the superior rectus.
Can I add something, Lionel? Later you operate on the superior rectus, stronger are the muscle. This is my experience if I operate very late DVD. I would say after the puberty. And this maybe can confirm what Lionel says. There is obviously a problem in demonstrating that the superior rectus is the cause, but the effect of this surgery on superior rectus is by far the best. So I don't think there is any question that the superior rectus plays a role in this.
Back to Lionel's, back to David Granite's point. David, I think the surgery we do for DVD is crippling surgery. I think the underlying vergence mechanisms which dampen the nystagmus are still happening, but you've crippled the muscles to prevent the DVD from showing. It's a purely cosmetic problem, I think.
And David, have you recorded, or Rich, have you recorded patients after these large surgeries and see what the effect is on the nystagmus?
Have not.
So
Rich,
interestingly,
Rich,
I can go ahead.
No, you go.
I have done recordings on patients pre and post-operative eye muscle surgery who've had DVDs in FMNS, and sometimes unless you actually do the torsional coils, which I don't do on a regular basis, you're not going to see the same types of changes that David made, or the changes that David saw initially. But what I can tell you, what we do see is that the nystagmus waveform improves, especially the FMNS. So the slow phase velocity decreases in the horizontal and the vertical component. When I record eye movements in these patients, the system artificially breaks down any oblique or potential torsional movement into the X and Y component. So I have a vertical movement recording and a horizontal. So we can put them together. There's programs that will put them together, but they don't give you a torsional movement. It's usually a Euclidean oblique movement, but it gets better. So without weakening the saccades. But there are crippling procedures where if you do superior saccadic studies, then they will be they'll be slower and they'll be dysmetric, especially if you've done a large superior rectus recession. That's usually associated with a -2 or -3 inability to elevate the eye. And you look at the saccade from primary position to up gaze. Remember, the use of the vertical acting muscles changes and is different in its coordination, whether you're looking from down gaze to primary or primary to up, whether you're looking in adduction and the same thing. So you get different forces in all these directions, but there are clearly improvements in the eye movement recordings. The slow phase characteristics are better. There's longer periods of low velocity slow phase, both in the horizontal and the vertical direction after DVD surgery. So Lou and I are not sure. We've studied this, and Lou's published a couple of papers with this in FMNS too, whether this is actually changing the mechanical characteristics of the muscles or acting on some proprioceptive afferents like in INS, or in those patients in whom fusion is improved. Is that why the nystagmus waveform is correct? So it's a little muddy, but generally when you operate on these patients, the recordings, the characteristics that make the recording bad get better.
Yeah, great. So why don't we move to Max's presentation, because complete the surgical approach to DVD. Max, please.
Yeah, thank you. Thank you, everyone. Thank you, WSPS. Thank you, David, for inviting me. I don't know if I deserve that, but I really thank you for inviting me. So I'm asking to talk about the outcomes actually in the dissociated horizontal deviation. Well, what we are talking about when we talk about DHD, I can't say anything more because David Guyton, of course, is a giant in this field. So he explained very well what DHD means, but I want to suggest this paper where they talk about DVD, but also DHD, and David Guyton was among authors. And I also suggest this another paper with by Michael Buchovsky, and he described everything about the DHD. And he also said the dissociated horizontal deviation can be detected in 50% of patients who develop consecutive exotropia following surgery for infantile esotropia. So it's very common, DHD. But, let's take a look at the literature. If we search on PubMed, if we search for dissociated horizontal deviation, we find about 25 results. And if we search for dissociated vertical deviation, we found about 283 results. So, there is a very huge difference. But let's move on. If you search for dissociated vertical deviation and outcomes, we found 30 results. And if you search for dissociated horizontal deviation and outcomes, we found just 1 result. So this is a kind of free zone. We have few data about that. We have few data about dissociated horizontal deviation. We have, about no data, or really, really few data about outcomes on dissociated horizontal deviation. For this reason, 1 year ago, the study started a couple of years ago, we tried to find a consensus with some of the panelists here today on the outcomes after strabismus surgery using a Delphi process. The Delphi process is a kind of process that helps, panelists to find consensus on some controversial issues on, controversial area. And why we decided to do that? Because when we talk about outcomes, whenever is the surgery, I'm talking about strabismus, any kind of strabismus, we know there is no uniformly accepted definition of a successful outcome after strabismus surgery. I want to read that. As some published studies have defined success based on motor alignment or sensory outcome or a combination of both. Other studies have described specific goals such as resolution of diplopia, compensatory head posture, restoration of normal eye contact, and the outcome criteria, including range of the single binocular visual field of necessity for prism or manipulation of accommodation, might also be considered in the definition of successful outcome. Well, actually, the published literature does not provide evidence-based studies to justify the use of any specific criteria to define success after surgery, after strabismus surgery. And this is important because given the most important point is that given the current lack of agreement on what should be considered as a successful outcome after strabismus surgery, it means that a given patient's outcome might be considered a success in one study, but a failure in another study. That's why I decided to study, to try to find a consensus on the outcomes. And if I take a look to the dissociative strabismus complex, we found a consensus on the sites of manifest deviation and also on the perceived cosmetic acceptability of the deviation after strabismus surgery, after surgery for dissociative strabismus complex. So what should we do? As Lionel said before, when he talked about the DVD, this is a free zone because we don't have so much data. Ed Wilson, Amy Hutchins, and Richard Saunders in Charleston. Actually, I was fellow there 20 years ago. They studied this, the outcomes, and their recommendations are summarized in this table. And they say that they use a 15 prismatic diopters as a cutoff to decide, the amount of recession. And if the HD is more than 15 prismatic diopters, they recommend a unilateral lateral rectus recession of 7 millimeters. If less than 15, a unilateral lateral rectus recession of 5 millimeters. If the HD is associated with exotropia, they suggest a bilateral lateral rectus muscle recession, and the same bilateral lateral rectus recession if the patient can switch fixation. And Michael Buchovsky says something similar in his paper. He said that we generally treat the combination of consecutive exotropia and DHD with bilateral medial rectus advancement only if the near deviation is greater or than distance deviation, and or there is an adduction lag with lateral concomitance. Or they suggest a large bilateral lateral rectus recession if the distance deviation is greater. What I do, I use the same cutoff using from Ed Wilson. I studied there, so I use the 15 prismatic diopters. My number are a little bit increased, a little bit more, about 1 millimeter more. So for DHD, more than 15 prismatic diopters, I prefer an 8 millimeters or unilateral lateral rectus recession. If DHD is less than 15 prismatic diopters, I prefer about 6 actually, unilateral lateral rectus recession. And they often have a strong preference for monocular fixation. But anyway, if there is a possibility to switch the fixation, or if there is an exotropia associated, as often actually happens, so I do the same as above, except for bilateral lateral rectus recession. What are the outcomes? If I consider as outcomes the size of manifest deviation and the perceived cosmetic acceptability of the deviation, I will say that none had manifest DHD frequently or greatly enough to be treated again. Well, I know that using words, like frequently and greatly are not numbers. And if you don't use numbers, it's not science, but it's opinion. But I think this is the best we can do, or at least the best I can do. Thank you.
Max, that was great. And it refers to so many issues that we have in strabismus about not even being able to define what our outcomes should be. Thank you for all of that. The questions that we're getting from the audience are, not surprisingly, from clinicians asking us about various different kinds of surgery. And that includes, should I anteriorize the inferior oblique for DVD? Should I recess the superior rectus? Should I shift both horizontals downward if I'm doing an R&R for infantile esotropia? Should, for dissociated horizontal deviation, should I look for the largest deviation I can, like we might in intermittent exotropia, and try and operate for that? They're very practical based questions. So let's take a moment and be practical and just ask the surgeons on the panel, what do you do in these various different situations? And we heard from Lionel already, but just very short, brief ways to help the people in the audience asking these questions. Max,
may I start? Yeah.
Yes.
Okay. Thank you, David. Just quickly and the practical answer, I suggest to go for the maximum angle first. I suggest to go for the superior rectus in case of DVD first, unless there is inferior oblique overreaction associated. If there is an inferior oblique overreaction association, I will go for anterior transposition of inferior oblique as first surgery. And then for second surgery, I will do inferior oblique if first surgery was superior rectus. And I will go on superior rectus if the first surgery was on inferior oblique, just to be practical.
Hello, I want to hear from you. You're a great surgeon.
So I do follow, Max hit the target. I do follow Wilson's recommendation for the type of DHD that we discovered, not exo, but ESO. But in that case, in which we found horizontal exo deviation, so the approach to the lateral rectus and one lateral rectus is my preferred choice, unless I don't see a problem in a deduction. In that case, I advance just one muscle. In DVD, I often operate on the superior rectus. I've never had bad results in operation. Maybe not a perfect correction, but superior rectus do not create problem to me. While if I operate firstly on the inferior oblique, I have often to reoperate. So this is just quickly my approach.
David Guyton, you implied in part that the DHD is really an ESO movement, and we're talking about operating on the lateral rectus, I assume for the underlying exo. Does any of what you've done change your approach, and how do you approach these from a practical standpoint with a patient in front of you or in the operating room?
You can have a patient with exotropia that has an ESO shift developing less exotropia. I didn't say ESO deviation, I said ESO shift. But a question that I still have is that a patient with a small amount of esotropia that builds up with cover testing. I used to think because they were partially fusing and they're building up because you're breaking fusion, but now I think it's DHD that's causing it to build up. Now, I always thought we should operate for the full angle of the Prism alternating cover test. But now I'm wondering whether we maybe should operate for the simultaneous prism cover test and let the DHD still act and help hold the eye straight. I don't know the answer to that. I'm developing new questions as I look into this further.
In strabismus, I can tell you something, David. Everything works. So this is the problem. So we have a lot of approach, and all they works. So.
Well, Paolo, I always think that when we have so many different approaches that we all think work, that none of us have the right answer. And that when we understand it better, that we can intervene better. But for the moment, yes, we all have these different approaches. And we use sayings like, in my hands, when I see patients, this works. And we still, the analogy I use is airplanes will be better in 20 years, but we still fly today. And we still have patients in front of us today asking us for help. Richard,
can I add something, sure. Dave? Can I add something? But this is not just the case for strabismus. If you think about atropine treatment of myopia, we don't have any perfect idea what is going to do the atropine that we put in as eye drops, but it works. So I will follow that line. Yes. Nobody of us knows that dopamine is really the reason for which the sclera is not growing, if the metalloproteinases, but still works. So if it works.
And Paolo, all of us who do, especially adult strabismus, have seen people operated on 50 years ago and seen the outcome. If I send my children outside for to spend time in the sun and they get a sunburn, 5 years from now, I don't think that's a problem. 10 years from now, I don't think that's a problem. But 50 years from now, it may be a problem. So when we talk about safe and effective and we don't have long-term data, it is worrisome. Rich Hurdle, we have people in the audience looking for some practical advice. Any practical advice for them?
Yeah, I have, I know. my approach is always a little bit over the top, but it's not unique because I was taught it again by Dr. Jampolsky. So when I see kids with DVD and esotropia and infantile strabismus, I do their horizontal procedure. Usually it's a bilateral medial rectus recess combined with the double whammy, Jampolsky's double whammy, which I use for chin down nystagmus. I do superior rectus and inferior oblique together at the same time with the BMR.
Pearson, can you please turn off your sound? Thank you. Go ahead, Rich.
And if I don't see superior rectus or inferior oblique overaction, I'll just do the BMR or an ROU. But if there's any evidence of DVD and DHD at the time that I'm taking care of the horizontal deviation, I just do all three right away, symmetrically, unless there's obvious asymmetry. But early on, it's usually pretty symmetric.
So this raises a question. David Guyton, in one of your papers, you noted that Cameron Parsa had suggested knocking out all the obliques for DVD. Rich, you do that sometimes with nystagmus, that you'll take out the obliques. Is there a role for that in DVD?
Yeah, I have multiple patients now in whom, as a result of multiple procedures or over time, or intentionally with acquired nystagmus, have had all four obliques completely paralyzed, tenectomies and inferior oblique, complete inferior oblique myectomies, and we've even done recordings on them. And we did this when I was at NIH with some animals who had coils put in. Then I took the obliques out before they were sacrificed. And as long as they have good fusion, or even without fusion, if you do symmetrically, equally, people seem to do pretty well. It's amazing how you don't need them if they're interfered with on an equal and symmetric basis. I'm not suggesting that you lop off everybody's obliques all the time, but I think that the idea of somehow that all four obliques are absolutely necessary is interesting, and they may not be.
Let me comment that Susanna Camio and Fernando Krieger in South America both took up that idea of weakening all the oblique muscles, and they did that and published results. About 60% got good results. So there maybe is a role in the future. We haven't figured out the best way to do that yet, though.
Yeah, I agree.
I've heard Art Jampolsky's name mentioned twice now, and one thing, a term that he introduced that I will change slightly, I think was great. He introduced the term bilateral monocular esotropia, and I really like the term of bilateral monocular strabismus as trying to explain the basic defect in dissociated deviations. David Guyton, do you like that idea?
Tell me again what your term was.
Bilateral monocular strabismus, or bilateral monocular esotropia, was Jampolsky's term.
I'd rather just explain what's happening rather than add a new term to the literature. But suit yourself, Lionel.
Okay, so we have 30 seconds each for the panelists for giving the last comment. So 30 seconds, please, because we are out of time. Anna, could you start you?
Yeah, I think it's been a fascinating discussion. I think coming from an orthoptics point of view, I think we need a little bit of work done on what it is when they're straight and what type of convergence it is that we're driving. Is it primitive convergence or the adult type of convergence that people with binocular vision have, but these groups don't seem to? So I think that's
great. Pearson?
Okay. Excuse me that I lost the connection for a while, and I have a couple of questions. For first, Lionel, the vertical transposition of the horizontal muscles can be effective in the treatment of small angle DVD. What do you think about this effectiveness? If they had any experience with this?
It's no experience, and I would suspect the result would be inadequate.
Okay. Daisy, your 15 seconds final thought.
One comment. and why splitting or pull a posterior fixation suture is safer instead of the superior rectus faden, because the superior rectus faden is a little dangerous for the applying. And I need to say about this. Thank you.
Any advice to us what we should better examine? That was my...
So, Lionel, do you do faden on the superior rectus?
Yes, I do faden. I've tried the pulley suture a few times. It seems to work very well on medial rectus and on inferior rectus, but doesn't seem to work well on superior rectus. The pulley isn't very solid there. Just
I have to come visit you. I have to come visit you.
Please.
How would you do the faden on the superior rectus? It is for me that I have 18,000 operation. It's still a very, very tough situation. Max, what about your last words?
No, nothing. Just thank you. I said my last words when I, comment for a practical suggestion. So just thank you, everyone.
I just want to point out that the advances are going to come from increased understanding of the basic sciences. And 25 years ago, David, when you gave your extraordinary talk at Palm Springs, the world of DVD changed because you pointed out the basic physiology. And 100 years ago, Alfred Buchovsky said that strabismus is difficult until you understand the basic physiology. And that's where the understanding is going to come, from understanding the basic physiology.
Okay, David Granite. So why don't you take the microphone and do the last announcement that you need to do?
Let's give David Guyton a chance to sum up, and then I'll go into housekeeping announcements. David, you get the last medical word.
Thank you, David. In looking into DHD recently, I really came to the conclusion that Edelstein and Cooper's with their nystagmus blockage syndrome were probably correct after all. And I think we have because DHD is blocking the nystagmus, the horizontal nystagmus, convergence with either eye fixing, and that convergence is going to shorten the medial rectus muscles. And I think that we'll find out that's eventually the cause of infantile esotropia. So if we learn how to get rid of latent nystagmus, we can prevent infantile esotropia. And that's fascinating to me.
So all we have to do is get rid of fusion maldevelopment and nystagmus, and we're good.
That's right.
I'm looking forward to that. All right. So I get to wrap up here. And I want to thank all the panelists, and I'll do that in a second, but I want to thank the audience first. We tried to wrap your questions into the discussion. This was an incredible discussion, but if you had any questions, you can email them to admin@wspos.org. We'll share them with the panelists, and we will put up a document as part of these webinars, which all live on the WSPOS YouTube page. I think there are some 50 now that we have there. They are phenomenal resources for anyone who cares about this field. You will learn so much just listening and hearing experts talk about every possible topic in our field. Coming up on the 21st of May, we have a joint webinar that we're doing with the World Glaucoma Association, and they will be joining us, and we'll be joining them for a webinar on pediatric glaucoma. We'll have experts from the adult glaucoma world and from the pediatric ophthalmology world discussing our overlap and what we know and don't know about pediatric glaucoma. It is a difficult and trying topic, and these patients need our help around the world. And so this hopefully is going to be something very, very special. I'm really looking forward to it. The WSPOS Subspecialty Day will be Friday, the 16th of September in Milan, Italy, Paolo's home city, where he will help run this. we are looking forward to seeing everyone in person. It's about time that we all get together and are face to face. The conversations in the hallway sometimes are as good or better than the ones from the podium. So we all look forward to seeing you on the 16th of September as a pre-day leading into the ESCRS Congress.
And Milan is beautiful.
Milan is gorgeous. It's a fabulous place, and my wife is already bothering me to join us together, and we're both looking forward to it. WSPOS has created podcasts from the Virtual Connect meeting in 2021. They are available on Spotify, Amazon Music, and Apple Music coming soon. Also available on our website. If you are in your car, in the train, anytime you're working out, if you want to listen to a podcast, these are snippets from the Connect meeting and are really spectacular ways to learn and delve further into our field. This is really exciting for me to have the opportunity to announce. In the year of the International Agency for the Prevention of Blindness, or IAPB's focus on child health, the World Society of Pediatric Ophthalmology and Strabismus is pleased to announce we have formed a partnership and now joined as an IAPB member. So WSPOS is an IAPB member internationally and continues to try and make every advancement we can to help children with eye problems and adults with strabismus. Remember, membership in WSPOS is free. We now have extra membership benefits for all that free money that you pay. You are going to get reduced charges for Karga's Ophthalmic Research Journal. You'll get one episode of the Journal of Binocular Vision, Ocular Motility free, thanks to the editors of the Journal of Binocular Vision, Ocular Motility for being willing to partner with us on that. We have all of our educational videos are free that are online on the WSPOS website. And you can stay up to date with all of the webinars. And I can't really say enough how great these webinars are, and thank all of the speakers that have participated and given up their time to participate in all those webinars. For those of you who like these discussions, the discussion exists ongoing. The listserv that was started in 1994 continues with 1,643 people as of today that are members, and it's very robust. Email me at my email address that you see here. Let me know who you are, where you did your training. And I have added every person since 1994 by hand onto the listserv. It is a robust and intriguing and interesting discussion. For those of you not involved, I recommend it. It's just been fabulous. Thank you again to the audience and to today's panelists, David Guyton, Daisy Gotts, Lionel Cowell, Max Serafino. I can't thank you enough for sharing of your expertise. It was an amazing discussion and one that I will go back and listen to again, to learn to again. Dearson, I'm sorry for your internet difficulties, but thank you for joining us. Rich Hurdle and Anna Horwood, thank you for your insightful comments and questions. And to my co-moderator, Paolo Nucci, as always, my friend, thank you for your expertise in all that you do and your great elegance that you bring to the table. Our hosts, Entod International, thank you again for all that you do and allowing us to be able to bring this great educational content to the world. And none of this would happen without the administrators for WSPOS. Aquila, those of you who've interacted with WSPOS know it. Danielle, Marie, we have just an incredible group of people who make it really happen and put up with doctors who are never easy and often are difficult. And so with that, I will bring this meeting to a close. And thank you for the gracious participation and understanding of all of our speakers and the willingness for the intellectual honesty that they bring for these kinds of discussions. It's really amazing to share our field with such wonderful people. With that, those of you who need to, it's time to go to sleep. For those of you on the western part of the United States, it's time to start our day and everything in between. God bless all of you who need it. And I hope our colleagues around the world who are under stress and in great difficulties are able to have a safety in their lives and peace in the world. Thank you all.
Thank you, David.
Thank you. Thank you, David. Bye all. Bye, everyone.
Bye-bye.
Bye-bye. Thank you.
Bye. Thank you.
Bye-bye.
Thank you, everybody, but I'm so sorry to lose very often. And I can't last my telephone. Excuse me again.
No problem, Pearson.
Person gole.
Glegole.
Bye, Lionel.
Okay,
Ciao, Lionel.
thanks a lot.
You talk, Daisy.
A biento.
See each other in Milano.
Ciao, Lionel. Ciao,
Thank you, David. Ciao.
Thank you.
Thank you, Anna.
Ciao.
Bye-bye.
Thank you, everybody.
Hi, Dr.
Bye.
Hi, Dr.
Bye.
Bye-bye.
Ciao. Ciao, Lionel.
Ciao.
Ciao. Ciao, Anna. Ciao a
Have a good
tutti.
day, everybody.